As we reconvene, we're going to talk about the title of this next topic is Universal Lessons from Connecting Rural Communities. And in rural areas of California, we are seeing innovations, and that's what this is all about. This is all, you hear this over and over again throughout the day. This is new stuff. It requires new policy, new payment models, new ways of accessing information. But particularly in rural areas of California, we're seeing that these innovations hold promise for many other non-rural areas of California as well. Our next session is going to focus on lessons that we can learn from these initiatives. And our moderator is a friend to many of us as the director of the Healthcare and Coverage Program with the Blue Shield of California Foundation, Richard Thomason. And he's going to introduce his panel and their topics, Universal Lessons from Connecting Rural Communities. And you will notice that some of our panelists are also movie stars, as evidenced in our earlier video. Everybody comes to California because they want to be a movie star. And so we have a couple in our midst. Thank you. Thanks, Richard.
Great. Thank you, Pam. So happy to be moderating the panel this morning and getting to share the stage with some of our movie stars here. With me on the panel is Dr. Earl Ferguson, a cardiologist at Ridgecrest Regional Hospital in Ridgecrest, California, which when you Google map it is about 100 miles east of Bakersfield in Kern County, in case you're wondering. Also, we have David Culberson, the CEO of San Joaquin General Hospital, and Jim Hauenstein, the Chief Information Officer of Enloe Medical Center in Chico and the chair of an emerging HIE, the Sac Valley MedShare HIE. I just wanted to take 1 minute and talk a little bit about Blue Shield of California Foundation and kind of what we're doing up here. Some of you know and some of you don't. We're a private foundation based in San Francisco that carries out grant making across California, and our mission is to improve the lives of all Californians, but especially underserved populations, by making healthcare accessible, effective, and affordable, and by ending domestic violence. So one way that we seek to accomplish this mission is by improving the integration and care coordination across different safety net providers in California, and that's really been our focus for the past decade, is on the California safety net. So we think that health information exchange is a key enabler of this safety net integration and of helping develop better systems of care for underserved Californians. So in recent years, we've supported about a dozen different HIE projects around the state, including some that you saw in the video and some here on the stage. Two key examples: we supported the Alliance for Rural Community Health in Mendocino County to work with Redwood MedNet, who's been a real pioneer in rural HIE. And then to improve the clinical information sharing between hospitals and community health centers in Mendocino County. We also made a grant that supported San Joaquin General Hospital and other stakeholders in San Joaquin to create the San Joaquin Community Health Information Exchange, which David will talk some more about. We recently published an issue brief on our website talking about some of the lessons learned from our work with the San Joaquin folks. We also published an issue brief about some of the early lessons learned from the e-consult work that you heard earlier in LA County, because that's also something that we've supported with our grant funds. So commend you to go check out those issue briefs on our website. Just want to highlight a few points from those issue briefs. One is in relation to HIE. One is that setting up health information exchange is a high degree of difficulty exercise that takes time and real commitment from the partners. You know, it's not easy and it doesn't happen quickly, as you'll hear more about. You know, and it's very important to clearly understand and identify the key needs before implementing an HIE, so you're able to really be clear about the exact types of information that need exchanging and the business case to support that. And then finally, it's we think it's really important to start with partners who have common referral patterns. So that will also encourage the business case and the business reason to work together. So with that, I want to move on to our panelists and have each of you talk a little bit about the HIE experience in your communities and the lessons that you're learning. So first, if I can start with you, David, talk a little bit about the evolution in San Joaquin.
Great. We've been about 2 years in this mission, and we're about ready to go live with data feed this month and really be up and running, exchanging full-time in December. And where we are at the San Joaquin Community Council is really simple. A safety net hospital, San Joaquin General Hospital. It's affiliated physicians, and we are we employ physicians as a public hospital here in California, so we have both primary care and specialty physicians. We partner very closely with a very large federally qualified health center. In our area, they have 5 sites. Community Medical Center has sites in Stockton, near the hospital. They also have sites in Tracy, Manteca, and Lodi. So if you're familiar of the Central Valley, San Joaquin County is a few cities and a lot of farmland. And access is very difficult, of course, in the Central Valley. And in our area, that's really true. And I can say that the HIE is pulling together a lot of us in ways that we have hoped that we'd be able to do. And again, later on this month and in December, I know when we really start sharing live data, it's going to make quite a bit of difference. We also are working with our behavioral health department, and I know Vic Singh is on the next panel, and very innovative approach of sharing information there, because we've really, with our work in the patient-centered medical homes, have really needed to have more sharing of information from our medical providers to the behavioral providers and vice versa. So that's real important. Another provider we have, or another important link we have, and I think driving an awful lot of it, is our local managed care health plan of San Joaquin. Medi-Cal provider to over 100,000 lives in San Joaquin County. We have a lot in common, both here at the hospital and the community medical centers, the FQHC, and also others in the community. We have, as you would imagine in the rural setting, an unbridled demand, and how we really work together to make things happen is something that we've got to be able to do. And lastly, we have a partner with also within the county, Public Health Services, Public Health Department, because they are our immunization registry for 7 counties in the Central Valley. We aren't part of the statewide CARES program, we have our own, and so there's a lot of sharing of information that will be going on. So that's a little bit about background. Rich, I think can talk a little bit maybe about the issues we've faced with, or do you want me to just let the others to introduce what they're all about? Okay, so you really you came here to hear this. A couple of things I think that are really important as we've, over the last 2 years, with the assistance of Blue Shield Foundation, come together, and the most important thing I say is the governance piece, how we come together to hold each other accountable when we've got different objectives. It's very, very important. We found that we need to have well-defined meetings, accountability. We need to make sure that there are agenda that are published in advance, that we stick on time. And as always, we get into the meeting, we get out of the meeting on time. And so everybody comes ready and is prepared. That's very, very important. We also have worked with Inland Empire Health Information Exchange, Rick Swafford's group here that spoke before us. And we have a seat at the table of HIE as well. And that's important. But our major focus of governance has been at our local level, pulling together the 4 or 5 partners here. Next is a little bit on a learning thing, the technical. We have a very old, I don't even call it a HIE or EHR at the hospital. It is paper-based. And we found that the ADT information goes back so long that a lot of the HL7 messages that are shared modern times never existed in prehistoric times. And think about the changes we've had. just in census information, ethnicity, marital status, religion, relationship to the patients have all changed as we've changed our, as we've had legislative changes here, both at the state and the federal level. So some of that information that we take for granted has to be updated, and we've done at an interface level rather than going back and reestablishing the databases. One important component we see also is people and the focus of management and staff change. At the health plan, we've had in the last 6 months a chief medical officer, chief executive officer, and chief financial officer all move on to other roles, and that means the health plan may not be focusing on our HIE the way we all would like. At the hospital, I've added a new chief medical officer and a chief medical information officer, all who have buy-in and want a seat at the table. That's why the governance is so important. How many voices do each of us get? We've had at behavioral health a movement on to the behavioral health medical director, and at community medical center, the physicians, the executive officer, the lead physician, executive officer, and chief operating officer have all left in the last year. So when we birthed this idea 2 years ago, the people that are still at the table now are quite different and have different expectations, different timetables that we all hope we'd be able to achieve this. And again, that's where the governance piece said, and external sources, quite honestly, our funding commitment was to get this thing up and running, not someday, but to get it up and running with a deadline. So that's been very, very important. And lastly, I think one of the things that I heard it this morning with Dr. Yee down in Los Angeles County and his experience in San Francisco County as well, you need to have a meaningful outcome that you can demonstrate to your physicians. We share our obstetricians at community medical centers. We put our doctors out in the community. We still are faxing records at week 30, 34, 36, 37, 38, and not all those records get to the labor and delivery suite in a timely manner. The HIE is enabling us to do that, and when we brought the physicians, particularly the obstetricians in, to say, watch what this will do, they said, that's powerful stuff. We can't wait. And in fact, we want to be able to tie this into an ultrasound provider that is not captive in our system, but is somebody that's is a very strong referral source or referral base. We refer an awful lot of our ultrasound to them. And now the doc said, you need to get them in as well, something we had not planned about. So, focus on a specific outcome that they could touch and live with, and the excitement really builds. So that's where we are. Hopefully hear more about us in about another month here when we really do start exchanging live data. Thank you.
Okay, I'm Earl Ferguson from Ridgecrest, California. We've been, can you hear me okay? I don't know what it is. Can you hear me now? Is that okay? Is it working? Yeah. Okay. You heard where Ridgecrest is. It's very isolated. It's the largest community, and it's got 26,000 people. It's the largest community in 12% of California on the eastern side of the Sierras. There are only 136,000 people that live there. And the two counties north of us, which we help serve, is they have 1 to 2 people per square mile, respectively. So it's very isolated. There are real challenges. And I went there to help develop telemedicine and other health information technologies, and it's been an interesting experience. The hospital was a very early adopter of EHRs. The clinic that I joined, as a cardiologist, I joined a primary care clinic with my brother and his wife, and really learned a lot about difficulties of rural health care. And I'm going to talk about a number of projects that I think are really transformational and moving very rapidly. One is the National Rural Accountable Care Organization. I'm now the medical director of that organization. We have 10 founding members. Actually, most of those are our hospitals, critical access hospitals nationwide. And actually 4 of those are in the telehealth network on the eastern side of the Sierras that I set up, and we've been operating over the last a decade. One thing about that, we talk about the triple aim. You're familiar with what the triple aim, but the Rural Accountable Care Organization really
adds a fourth aim. We think there are really four aims, and one is we've got to have financial stability and sustainability for rural health organizations, and we think we can do that. And let me tell you why and how we can do that. One is this one thing that's really transformational for us on the eastern side of the Sierras is the Digital 395 Broadband Technology Opportunities Program grant. It was a $101 million grant to lay fiber all the way from Barstow to Reno, mostly along Highway 395. And I've been on that board, and now we have all the fiber connected. It's 565 miles of fiber, which, as currently configured, will conduct greater than 4 petabits per second. I had to look up what a petabit was. You know, that's like 1 billion megabits. And we think that system will last for 100 years. That's our projection. And so I think that's really going to change things. We are connecting about 260 anchor institutions, which includes all of the critical and other, schools, libraries, just all the not-for-profits. In addition, we're going to lease broadband we've already leased broadband to all of the carriers. So they will be able to connect businesses, homes. And so I think that's going to completely change the economics of the eastern side of the Sierras. The second thing that and by the way, the cost of that broadband is less than 5% of what we were paying before. So it's going to be much more reliable and a lot more cost effective. The second thing that we've been involved in is coordinated cardiovascular care. And as a cardiologist, I'm very interested in that. So the broadband is going to allow me to read in real time not just echocardiograms, but CT angiograms, and set up a CT angiogram program to evaluate patients that come in the emergency department. And I can do it 24 hours in real time to evaluate people that come into the emergency rooms, not just our emergency room, but also two of the critical access hospitals to our north have 64 slice CTs, and we can set up a program with them as well. So I think that's going to make a very big difference, because it should decrease the need to transfer people out of our area by about 80%. And it markedly decreased the time in the emergency room, the need for hospitalization, and so on and so forth. In addition, like I said, four of the critical access hospitals in our region are part of the National Rural ACO. We're using the Inland Empire Health Information Exchange as our data bank. That should be set up in the next few months, and they're going to provide all the data analytics, so on and so forth. It's going to be a pretty comprehensive system. We're working with actually Stratus Health in Minnesota to help us with a lot of the foundation of this, the coaching, and so on and so forth. Lessons from ACO experiences. Interesting looking at the Pioneer ACO experiences. One of the ACOs that decided to change the Medicare, the shared savings program rather than continue as an ACO, listed 4 issues that you got to deal with: focus on data, engage patients, rethink emergency care, such as have emergency rooms for geriatric patients, because that's an entirely different group of people that need special attention. 4, expand the workforce. I would add 2 other things. First, implement evidence-based guidelines, standards of care, and also not just for providers, but also for patients, and give them things to follow so they really know what's going on. And then the next 6 is we've got to simplify physician and other provider tasks. So we got to make it simpler so those people can concentrate really on face-to-face time with patients and less on administrative and other tasks. Yeah, all these are difficult solutions, but advanced health information technologies are the key to make all this stuff happen. I think, I heard in the previous session, or maybe 2, I can't remember which one, talking about we need to get away from fee-for-service. Well, I think we need to move from fee-for-service to fee-for-value. But we have to make sure that we provide adequate incentives for people to develop innovations and profit from doing things efficiently. And so that's going to be key to making all of this stuff happen. And the sixth, financial sustainability. It's interesting, the CMS estimates that the three-year cost of establishing an ACO are about $4.2 million. So small facilities are not going to be able to do that. In fact, the American Hospital Association thinks it's really 15 million over 3 years. Well, the model we have, because we're aggregating a large group of people with the National Rural ACO, we think we can provide that for about $11,000 a month. That's a big difference. So think about those issues, and I think examine them. You know, I think you're going to have to look at all the ACOs. I think there's going to be a lot of consolidation of ACOs, and so there are going to be a lot of changes to look for.
Hi, I'm Jim Howenstein, CIO at Inlow Medical Center and the chair of Sac Valley MedShare. But before I start, we've got 4 members of our executive team here, and I want to introduce them so that during this next 5 hours or 6 hours, if you've got questions about what we're doing with Sac Valley MedShare, you can ask them. So first, I've got the CIO at Oroville Hospital, Denise LaFleur. She's here. Dr. Attila Kaza, he's there. Dr. Dorsey Tyler, both from Inlow. And then our real stakeholder here is Suzanne Ness from the Hospital Council. We started 14 months ago, and we signed our vendor agreement at the end of October to go with ICA. But what the journey has been is this team that I just introduced, they've been there almost from day one, meeting every 2 weeks for 2 hours. That's a big commitment that they have made for having a HIE in a rural community. How many hospitals do we have? We have 4 acute hospitals. There are Rideout, Oroville, Inlow, and Feather River. Interesting enough, we do not have a Kaiser, Dignity, a Sutter in the area, but they all have different software. And then we have critical access hospitals of Seneca, Briggs Gridley, Glenn, and we're looking at Colusa. The areas we cover is Colusa, Sutter, Yuba, Glenn, Butte, Tehama, and Plumas. That patient base is about 500,000 patients, just a little bit above 500,000 patients. We have approximately 20 people at the table every 2 weeks, okay? We have behavioral health there. We have public health there. We have North Valley Indian Tribal. We have Feather River Indian Council. We have the four hospitals there. We have the critical access hospitals there. And during this period of time, the challenge has been to stay focused. You know, we all want to have an HIE, and it's taken everybody has taken, from what I understand, 2-3 years to do it. When I took over as chair, I would have liked to have done it in 9 months. Guess what? We couldn't make 9 months. But I think we've done a pretty good job at 14 months. And if you look at, I'm going to use an example, Denise over here from Oroville Hospital. She has a full-time job, but she also headed up the team to evaluate our software vendors. Everything has been a team. Everybody is working as a team. Now that we have signed the contract, the work has started, and it's not going to let up. I was out for a while, and I said we could stop the meetings. The member said, no, we've got to meet every 2 weeks, and we've got to continue to meet every 2 weeks. We have had no funding. We've had 2 stakeholder dinner meetings with our stakeholders. In fact, our last one, Pamela Lane was there as part of the program, and it really kicked it off. And the stakeholders were so impressed that Pam was there, but not only Pam, but we brought a person in from Central Illinois, Joy Dooling, who has addressed people out here. So I'll just leave it there for right now and turn it back over to you.
I don't think they were impressed that I was there. I think they were impressed that all of this is happening and that you all were coming together in this business meeting, but thank you for the kind words. I don't think we're going to have time with this session for questions, but memorize their faces. You won't see them on your milk cartons, but memorize the faces, because these are the folks you want to ask questions of regarding the lessons learned in the community and in establishing a community HIO. And it takes longer than you think, but it's certainly very doable. And gentlemen, thank you.